Hi, this is Dave Lockwood with Percussionaire Corporation. This is the last in our COVID-19 interviews with several advanced clinical practitioners who have had experience using our IPV and VDR ventilators for COVID-19. So without any further talk, I'd like to introduce David Schramm. Dave, can you tell us about yourself?
Okay, thank you for inviting me. I'm David Schramm. I'm physiotherapist working in Genk in a hospital in Belgium. I started working on intensive care in '94, and I was used to work with the things we had learned from in our as physiotherapists, but working on intensive care on very severe cases and patients who need very great help. I was searching for better things to have better results because I was limited with my knowledge and with what I was using on the patients. So I started searching. I found the IPV. We started with the IPV in '97. In 3 months, I got very good results, and so the doctors asked me to continue with the device. We saw very good results on the X-rays. We saw a very good result on the clearing of the lungs. So we started in '97, and after 3 years of experience with the IPV, we started with the VDR in 2000. And so we are still working with both devices now in 21. We are doing the ventilation and also the treatments with the IPV. We started on the intensive care with the IPV, and then it was introduced on the ward because patients started on the intensive care and then went to the ward. So now in all the hospital, it's used on severe pathologies.
So with IPV and COVID-19, how have you been using it? A lot of people are concerned about using our products with COVID-19 with the concept of the high frequency possibly causing aerosolization of lung content and potentially, spreading COVID.
Yeah.
How have you used it? What have you done as far as protecting yourself?
Yeah. So because it was known as an open system, open to the environment, and that was the quality of the system. They were in the hospital. They were afraid to use it on COVID patients. So because we didn't have the protocol by using the bacterial filters and so on. So we came together with the doctors and they decided not to use the IPV on the COVID patients because they were afraid of the aerosols. The aerosol. So instead, indeed, we didn't have a lot of experience using the IPV on the COVID patients, but it's still used on non-COVID patients. What I did instead is using the IPV as treatment, as a recruitment treatment on COVID patients, and then I used it in the way the protocol told me. So with the bacterial filter, and there we had very good results. We used the IPV directly on the tube of a patient who was ventilated in a conventional way, and he was also on the ECMO. So I put the IPV in line directly on the tube. So I disconnect the patient from the ventilator and put him on my IPV. And so I ventilate him and did the recruitment at the same time, 1 hour and a half in the before noon and another session in the afternoon. So two treatments of 90 minutes of the patient with the IPV. Yes,
That's
together.
interesting.
Yes.
That's interesting. And most people look at doing a 15 to 20 minute treatment every 6 to 8 hours. You chose 90 minutes every 12 hours, and you saw great results. What was your thinking or rationale of doing a longer treatment, but not as often?
I think it came from an earlier experience that we had with patients with a closed lung, with the atelectasis of a total lung, that I proposed to put on the VDR in a non-invasive way. So that were patients sitting in the chair with the tracheostomy, and they had several days bronchoscopy to solve the problem. But each day we saw again the lung totally collapsed. So I proposed to doctors to use the VDR in a non-invasive way, so more in the way of the IPV. And I put the patient in the chair. I put him on the VDR with the settings of from the IPV, and we saw that the lung was clearing, and that we had the possibility to do the recruitment of the lung. So that was for me the idea of doing the same thing now, but with my IPV device and using it for a longer period. Because when you have to open, when you don't have really the problem of a secretion, but more a closed lung, you need more time to open the periphery and to have the same effect, of a good effect.
I agree with you 100%. And interesting here in the United States, with our competition from other companies, they tell people, at least with their products, a 5 to 10 minute treatment, and it's satisfactory. But again, we have not seen that with Percussionaire, and people using our equipment will agree, a longer treatment, better results, but you don't have to do it as often, and that appears exactly what you're saying.
Yeah,
Had other ones do them as long as 4-hour treatments to a patient.
Yeah, so I think it's really important. You have to know what your problem is. When you have a problem of an atelectasis caused by a plug, then probably sometimes you can work 10 minutes, 20 minutes, and the plug is away and the lung is open again. But here, when you have a patient who is ventilated on ECMO and on in the supine position, you know that when he went to the CT scan, we saw that the dorsal parts of the lung were totally closed. So it's impossible to open this in a treatment of 20 minutes. So we were able, what we saw is by using the therapy with the IPV 2 times a day for 90 minutes before noon and afternoon, we saw that we had the possibility to reopen the dorsal parts of the lung without putting the patient in a prone position, because that was difficult with the ECMO.
Interesting. And you had mentioned before, you had discovered too, with patients who were too difficult to prone or too fragile, you had mentioned about putting weights on the patient's chest and seeing positive results. Can you explain that a little bit?
Yeah, in Belgium, we are used to, as physiotherapists, we are used to work on the lungs and to do the recruitment. And the way we are thinking is that the what we try is to bring air behind obstruction in the airways, and once we have air behind the obstruction, we can create a positive pressure behind the obstruction. It means that filling the lungs with air is good to have result on the obstruction. And we know that the IPV, the percussion, is a very good way to do this, because we are using very small volumes which are able to go to the periphery of the lungs. So what we do with the weight, it's what we are doing with our hands. When we are working with the IPV, we are working with the hands on the thorax to search the level of the secretions and bringing the lungs to the expiratory reserve volume. And we are able to do this because first, the IPV, the percussion, is an open system. So we are able to search the region where the secretions are. And by the system, by the small but very small volumes, we are able to fill behind the obstruction. And once we can create there a positive pressure by the means of the inspiratory and expiratory volumes of the percussion, the obstruction can start moving to the upper airways.
So would you say with putting the weights on the chest that it kind of, with the high velocity laminar flow, it helped to direct the flow away from the front of the chest and more towards the dorsal aspect of the chest?
You can, yes, you can help. You can help by using the weight. You can bring you can work more in the periphery, in the smaller airways, and that's what we saw on the images and the X-rays. Yeah,
and obviously it worked for you with X-rays and CT scans, which showed that it worked. Yeah, that's I would love to have another whole meeting on that. That sounds quite fascinating, and I think a lot of people would want to hear that. Can you tell me now a little bit? You started using IPV with COVID patients, and then you have done the VDR with COVID patients. Is that correct?
Yes, that's correct. Yes. There was a patient on ECMO, a COVID patient on ECMO, but he had severe problems of bleeding, and he was bleeding everywhere, and I think he was kind of hit, so he had a problem of I don't know how you
thrombosis.
Yes. So a problem of when he was bleeding, it wasn't stopping. So they had to remove the ECMO. And the doctors, they asked me to put him on the VDR before the ECMO was removed. So I put the patient on the VDR, and he was for 24 hours on the VDR together with the ECMO. And the day after, they took away the ECMO, and we were able to ventilate the patient in a very good way. So the problem was that what we saw on the curve of the VDR, that the lung was very stiff, so that it was the compliance was very low. So the settings I had to use were not so easy, were not the same as all the other patients that I was used to ventilate. So we had to use higher peak pressures just to see that there was a volume going into the lung. And what was very strange also, so it was that we had to use a higher PEEP level, what we didn't expect, because I thought that using a lower PEEP level and a higher peak level gave us a higher delta P to evacuate the CO2, but I had to use a high PEEP level because I saw that with the lower PEEP level, the CO2 was increasing. So with a PEEP level that was too low, we saw that the airways were closing again. So
That's
it was
exactly what I was thinking.
yeah. It was so it was a little bit searching, but we were able to ventilate the patient on the VDR. Yes.
I have seen actually here in the United States, not just with COVID, but some places that have been ECMO centers, or what they have been seeing is they thought they needed to transfer the COVID patient to an ECMO center, and the ECMO center was full. They weren't accepting anybody. They chose to put them on the VDR, and they never actually had to go to ECMO at that point. They were able to finally liberate the patient from the ventilator without ECMO. So that parallels a lot of what you've just been talking about. So, you know, this has been very fascinating. I thank you for your time, and I definitely would like to talk to you more about the using the weights. I think that would be a great presentation to offer people in the near future. And again, Dave, it's a pleasure knowing you and working with you.
You're welcome. It was nice for me also to talk with you, and it will be a pleasure to work together in the future.
Okay,